the head of the delivery research division of ICMR. She is Scientist G, and ma'am has been very closely associated with our college also. So, ma'am, firstly, like you started your career from this institute, and you after PG in a case we can say we remember. Then from there to your daughter also was educated from this institute, and now you are heading the delivery research division in ICMR. How did your interest in implementation research develop from the starting? If you can explain in a few words.
Thank you, Dr. Aman. Good morning, everyone. It is very proud privilege for me to come and address this audience. First of all, I would like to thank Dr. Raina, uh, who has said very high about me that I left the seat and he got the seat. Maybe it is not like that. The person who deserves it gets it. Okay, so he has been the deserving person there and he got it. It is not material. Even if I would have been here, probably you would have got it. Okay, so it's all the caliber, it's all the person's intellectual skills and all that which make a person higher and higher and occupy that position. So, thank you, Dr. Anna, for organizing this National CarCon event and putting this very important session in a different way, in a podcast way that probably it is not time limited as well, but more open in discussion. So, as you said that I began my career from this institute. I began my career way beyond prior to this institute I joined. I did my MD from PGI Chandigarh, and then I think this is a journey of everybody's medical professionals who has done an MD as well, and they keep having different careers. So I worked in PGI. I worked as an ad hoc assistant professor in PGI. Then I came here. So I left the PGI position, and someone else is occupying that position. If I say that, because that is his destiny. And here also I worked. But fortunately, God gave me a chance that yes, I had to work in Indian Council of Medicine. Since beginning itself, I have worked very closely with the health systems, and apart from that, I have seen the evidence also being generated through the uh, elite institutions like AIMS, PGI, and other medical colleges. So, from 2005 onwards, when I joined Indian Council of Medical Research, it was since that time, it was in my mind that how do we engage as maximum as possible faculty or the doctors or the physicians or the healthcare providers on this country to have a broad base. But that was again a big challenge for me. So, in around 2010 or 11, when we had carved out the Department of Health Research, there the larger functions of the research fraternity came into vogue. So, because of my real interest with the systems, with the public health, and seeing that how we can translate the evidence for the program, so we carved out a scheme which is called as Model Rural Health Research Units. That's a very big scheme now, which is central cabinet scheme along with multidisciplinary research units. So those are bigger initiatives which really imbibed me to undertake some of the implementation strategies based on that. Yes, if we engage the medical faculty, if we engage the health system officials, probably we are going to make a difference. That was one aspect which I started with that. But apart from that, apart from these two bigger initiatives, I thought the evidence is not being generated enough as we have the large masses of faculty in the country. We have many institutions. So that was a gap which I thought that I must discuss with my leadership with ICMR and have certain programs like I did research methods courses across the different parts in the country. So that is how this MRU scheme has also come up.
Thank you, ma'am. Ma'am, I would like to listen from you that what is your understanding and of implementation research and implementation science? How would you like to explain to the naive people that what implementation research and implementation science means?
Implementation science and implementation research. Should we call it as implementation research or should we call it implementation science? So both are different. Okay. So when in 2000 and recently, we had, I mean, just to let you know that how the shift from disease not disease classification, the working pattern Indian Council of Medical Research changed from different divisions to the extramural and intramural program. Before I come to implementation research work being done and how do we define it and how do we carry it out, what are the methods into doing that, I will just take a couple of minutes to explain that with ICMR. And I think those who know that we had divisions like non-communicable diseases and communicable disease and epidemiology and reproductive child health, and those were the bigger divisions with ICMR, apart from some smaller division which was Indian Journal of Medical Research and Publication and Information Division. But when we had looking upon some of the country perspectives, like we see that when the parliament is meeting and when the MLAs and those people who raised questions, they used to ask us that how much has been the program benefited by the research being done on diabetes. Then we were all thinking aloud and asking from each of the divisions that what the program has, how much research has been done. For example, I talk about the diabetes research or we talk about the TB research. So we had to ask so many program officers within us and even Ministry of Health and DBT and other officials also that is there any strategy which has changed the program. So apart from asking individual people, we thought why not to have a separate section which is directly related to the kind of research which we are doing. So right now we have the 4Ds, which is the extramural division. We have starting from the discovery. Like discovery means like any of the researcher who wants to find out a new molecule, new diagnostic test, new pathways, new associations, new risk factors, or animal studies or preclinical studies. We put all the studies into the discovery part, okay, because that is still to come up and does not taken much of the place. Secondly, then is a development stage. Now when we say the development division, what does development division does? The development division has, you say that okay, I want to develop a model, I want to develop an algorithm, I want to develop a guideline, I want to develop a device. So wherever we are developing some things which is going to impact the health, we put all the categories of those research into the development category. Correct? Third comes the descriptive, where we were thinking about, and it all encompasses epidemiological surveillance, surveys. Like they want to say, I want to find out the association of obesity with the metabolic syndrome, or whatever risk factors you find it out, with a description of a condition or a description of a risk factor or an association ascertainment, that will go to the descriptive. Like we're just describing the burden or scenario or the magnitude of the condition. Lastly, which is very, very important for which we are going to talk about is the delivery division. Now, the delivery division which I am heading with the ICMR majorly pertains to the work in the implementation research. Now, in implementation research, it's very, very clear, and those who have read little bit about implementation research is that it is that kind of work systematically done into the system where we have the proven interventions. Like in a hospital setting, you have developed, like development research, you have developed a robotic model in a research settings. Like you have developed the guidelines, you have developed some new randomized control trial drugs, methods that is working in a research environment. But in those research environment, when you take it, the research environment to the real environment, ultimately everything has to go to the program, ultimately has to go to the population. So when we take the proven things, the efficacious things, the effective things, it is going to work into the community level also. That we process, we call it as a implementation research. Very, very clear. But implementation science is, so doing the art of that implementation research is implementation science. So research has a proper hypothesis, background, objectives, methods, protocol, stat and all that. But the whole science behind it, how it works, is implementation science. So there are n number of examples which Indian Council of Medical Research, not only ICMR, but it is, I think it is a notion which we are, now calling it at. It's not that we were not doing the implementation research earlier also. People had been doing it. There are researchers across the country. So that is how the evolution of delivery research and implementation research with an arena of ICMR has come up broadly.
Very beautifully put through, ma'am. Now, just to explain it a little further, although half of it you have answered. What is the difference between implementation research and operational research or health system research, if we say, and how can we differentiate it even from an randomized control trial for a early clinical researcher for his better understanding?
Yeah, I think you are coming to the more depth of how to undertake the implementation research. That itself is, the whole session, which, and it's a kind of a workshop what we do. First of all, it is very, very important to understand the clear difference between what you said as such. When I say the implementation research, I already said that implementation research is putting the proven intervention, it is not a new intervention, the proven intervention into the system. I'll explain with an example, right? Now, example I take, everybody knows that the integrated kangaroo mother care, IKMC, is an intervention to prevent the baby from early neonatal mortality or to prevent early neonatal childhood illness or so on. So that is one intervention which everybody knows is working, is effective, is cost effective also, and it improves the results. But now when we give the integrated kangaroo mother care, IKMC, into a hospital setting, which is a tertiary level setting, it will work. Okay, because we have the nurses 24 hours, we have the pediatricians, we have the neonatologists, we have the proper wards which is taking care of that, and it will work. If you do the randomized control trial on it, you will have one group which is getting the conventional care and other which is IKMC. That there will be a better outcomes when we compare with both of these. Now, when we take this IKMC to a health systems officials, health system program, will it work? It should work because it is a proven intervention. But now, under IKMC, when we go to a community health center, which already has a mother, babies are delivering in lower facilities also.
Yes.
Okay, but in mother and newborn, but this intervention may work, but not as effectively as it works into the tertiary care hospital, like in a tertiary setting or in a research setting. But when it works in the real setting, there are challenges. Okay, so when we have the challenges to integrate this proven intervention into the health system, so what implementation research will do, that how to integrate this IKMC intervention into the real scenario will be the implementation research, and I'll come its broader framework also. Let me come back to what operational research you said. Now, in operational research is to find out that this program, like you said, the IMNCI program, okay, you have the whole program. Now, IMNCI program, or it's a mother and childhood program, or whatever program names as you say that, whether this program is operating well or not. You get my point?
Yes, yes.
The program is operating well or not. That particular kind of research will be an operational research, and in our category, that may fit into the descriptive research. It's not an implementation research. Okay, so in operational research, where the National Tuberculosis Elimination Program is efficacious, effective, working well, operational parameters, yes, we may say yes, we may say no, we will come out some data and say it is working good, better, best, average, poor, whatever. That's an operational parameter. But implementation research will be that how to improve upon that particular program through that intervention like that. Lastly, you said the
Health systems.
health systems research. Now, health system research is something in between. Something in between. How in between? When we try to integrate the implementation of the intervention into a real scenario, we try to put up the individual 6 blocks of the health systems, right? You all know the health system 6 blocks: leadership, governance, financing, human resource, capacity building, and availability of the drugs and diagnostic. But when we are doing all these integration, probably we may touch upon any of these components. They either can be done independently or they can be done collectively also. Right? For example, IKMC. Now, IKMC is an intervention, but how to make this intervention effective into the program will require some kind of leadership also. That will also require some kind of human resources also, budget also, some policy implications also, and devices as well. But individually, we talk these 6 pillars on one of the component, available, not available, that will be the health systems research.
Yes,
Of
ma'am.
course, I hope it is more clearer when you do that.
Yes, ma'am. One common myth is that implementation research is very difficult. It is very complex. So, like people are confused sometimes regarding the design of implementation research. Will it be always experimental, quasi-experimental, or even observational studies are even good enough, good for implementation research? So, can you put a light on this?
First and all, yes, implementation research is not easy. Like now, we were doing such kind of a work in ICMR, around, I'm there for last 20 years, but last 7, 8 years, we are more into the implementation research, and last 3 years, very exhaustive work is being done in the form of the National Health Research Priority Projects. I know all of you should be aware of the NHRP. I will take this opportunity to explain that we have 4 categories of the research projects, which is small grant, intermediate grant, Center for Advanced Research, and National Health Research Priority Projects. Now, National Health Research Priority Projects are in alignment with the national programs. Okay, like we have the health and family welfare, we have all the national programs: blindness control, mental health, cardiovascular, TB, malaria, all these programs. In similar tune, we have the National Health Research Priority Projects. So these priority projects, like we have on mother and child, we have on NCD also. They all are working very closely with the National Health Program. So we cannot say that programs are running separately and research is in different direction. To make the research in alignment with the National Health Programs, we started NHRP projects. Now, when you say the methods, NHRP projects are being done in a setting, and that minimum setting is a district level setting. Okay, so in district level setting, to make an effect, we are not taking the entire Himachal. We may take one district. I don't think so that in Himachal we have one project in district Solan where the entire district has been covered. But in some of other projects, because this is competitive, so those who apply and something good background, they get the NHRP projects. So these coming back to the methodology, not talking about much about NHRP, the overall design of the implementation research, all of you should know that there are 5 major domains. First, I'll explain the 5 major domains, then we will come to the methodology. Now, what are those 5 major domains? Who is being affected? Who really makes implementation research is a good IR project is certain factors which influence the outcomes, like which we call it as a CIFAR model. I don't know how many of you have heard about it, which is a consolidated framework of
Yeah, bro.
implementation research, which is CIFR model. Now, what CIFR model is? Taking example from your state, we have an outer setting, we have an inner setting, then there are three other boxes. Now, the outer setting is the policy, the state, the decision makers, like who will be the outer setting? Your secretary health, your health minister, or your director of health services, or whosoever is the people who are going to make the decision on particular intervention to be implemented in a broader way, is the outer setting. If there is no political will, we cannot do the implementation research in the state or in the district in a larger group. So that one setting you will have to identify, that is an outer setting. Now, what is the inner setting? Now, inner setting is you want to do the work in a block level or the village level or at a district level. You have to find that inner setting, whether the component which is being addressed either to the paramedical health workforce is willing to do that. Is there any capacity to do that? If you want to put up the climate change through Asha workers, are they ready to do that? Is there any skill? So that inner setting also influence the outcome. So that is outer setting, that is inner setting. We have to identify who is that inner setting, and they have a great influence on the, in community also there could be inner setting. If the intervention is working around the mother and child or the or whatever the question you have identified, those community also sets the inner setting. Now the third box is that intervention. You are not going to test the intervention into this research group. That intervention, the systematic review or the meta-analysis through available literature, we know that this intervention is working and how much dose of that intervention is working, how much is the concept of the intervention is working. So that is the third box, that intervention has to be working. Fourth box is the researcher, okay, who will carry out, who will propose. For example, the medical college, the faculty from the medical college Tanda or from IGMC or from any other institution will be the main force who will have contact with the outer setting, inner setting, and intervention is an important component of delivering that implementation research. He is the one who will know that how it can be done. Okay, and fifth box is the independent evaluators, independent people who are going to see from outside whether things are making a change or not. So if you go in the context of the CIFR model, it's very well explained, but what is lacking in the project, I'll come to the project also, which are being received by ICMR in implementation research. They just put up a diagram of the CIFR, but they do not explain who is our outer setting, who is our inner setting, what is the intervention, who is going to be the reviewer and the observer, or who is going to be the indicators of those models. Now, coming back to what you asked about the methodology, implementation research, for example, you start today, okay, and you cannot say that I'm going to have improvement at the end of maybe 3 years. It will take some time. But if it has really changed the system scenario, that we can measure. So how it can be measured? We do the formative assessment. That can be done with an observational study design. We don't need to have some kind of a trial and all that. So implementation research is a mix of the designs. We can have the observational design, which could be cross-sectional study at various points interval. It is not that we are doing it every, just do the one cross-sectional study, do it at the end of the study. Now we have the neonatal mortality reduction. We are doing it in 10 districts in the country. We are measuring the neonatal mortality, finding out, having a cross survey every time, when we feel it, whether intervention is working or not. Okay, so cross sectional design, observational design is a part of that formative stage. Now when you say that the qualitative mixed method, that also can be embedded into the implementation research, and of course without qualitative interviews or quantitative estimation of the indicators, you cannot perform to say the outcome of the implementation research. And lastly, we do the pragmatic trials also. Like we have taken one district to see the effect. The health secretary may like to know that in district Solan we are working, but in district Chamba, that's a comparator district. So it itself comes at a pragmatic, trial within the geographic terrain. So it is not that only one study design will be sufficient. Depending upon the question, it could be, of course, the cross-sectional, the trials, and the qualitative and quantitative mixed method, they all come into the implementation research.
Thank you, ma'am, for that exhaustive reply. Now, just to clarify, like for you, you have been evaluator of multiple projects on implementation research. So, what design compromises are acceptable for you, and where do you draw the red line that this is not acceptable in the design of IR?
I will not say that design, only the design part is a faulty design, but I'll say that overall concept of the implementation is also not so propagated among our researchers. They say that okay, it is a research of the medical college, I only have to do. The biggest thing which I have seen in most of the implementation research projects which are being submitted now is team of stakeholders. They do not know that who will be my stakeholder. They know it, but they have not engaged with the stakeholders. The biggest thing which I have felt is the stakeholder composition. They have to take the people from the state, they have to take the investigator from the district, they have to have the preliminary discussion, they have to take the need of that undertaking that intervention into that district a priori before even putting up the research. Okay. Now the second thing, when you say that what not makes them into an IR is, of course, design is also important. But when they put up the design, but they do not put up that how are they going to evaluate whether the implementation research is working or not working. So again, this is again a missing thing into most of the IR proposals. Lastly, what is missing into the IR proposals is the prior experience of the investigator to work very closely into that program. So I have seen the research projects from one researcher in multiple areas. How can a researcher working in tuberculosis can also work on metabolic syndrome or can also work on climate change? So the whole track of the career and the pathway in particular domain also is important when we are going to review. And now we are having a very transparent mechanism of the review. We are getting the projects reviewed by multiple experts, and if there are scores one directional, we take the decision. If there is a ambiguity into the scores, we put a committee and decide upon that, about the merit of that proposal.
Last few questions, ma'am. It is often said that implementation research, it bridges the gap between evidence and practice. So, ma'am, how is are there any examples that you've seen in how this gap has been bridged in primary care settings or in hospital settings?
Yes, very important. I will quote two examples over here. One of the example is again that reducing neonatal mortality, and we have given this project name which is called as Sankalp, and it has its acronym which has evolved from neonatal mortality and all that. So when we started this project, I'll just give an example of two districts in two states. One is Madhya Pradesh and another is in Ambala, which is in Haryana. Okay, so in these two districts, when you say that it is how it is working, and so these two states, when you say that it is bridging the gap, yes, it definitely is helping the bridging the gap, because it is their priority as well. Okay, so when our officials, along with the officials from AIMS, like I said, there has to be researcher also, met the mission director NHM or met the chief secretary Madhya Pradesh, and they say that why are you doing only in one district? We want to hear every month how my, and there's a competition now, right? My district should achieve the neonatal mortality as soon as possible, because that will become the prime minister agenda. Apart from, leave aside the prime minister agenda, leave aside the state-wise or district-wise competition, why should a neonate who can be saved should die? because of our health system and appropriate interventions which are already there. Just because of they didn't get the IKMC, he didn't get the early breastfeeding. These are all the low cost interventions. Only thing is that they need appropriate methods for documentation, for initiation, for advice, for counseling, which is totally dependent on our ASHA workers or the staff nurse or our doctors or the community as well, or the mothers or the family caregivers also. So yes, it works. It bridges the gap. Number one, but number two, it also becomes a challenging when we talk about the resources. They talk about the human resources, but when we say that, can you do it, they are so willing to do it. The health system said we are prepared, tell us how can we do it. Then put the neonatologist into the press where we have the maximum deliveries, and put the mother, and I think you have the mother and child block which has really come up. It's all because of that political drive, and all the tertiary care hospitals are having, why not to keep the baby near to the mother, why are we taking the baby away from it? So that works, but with the challenges it works. Why we are not able to still do make a dent into tuberculosis? Because you should know that until unless there is a unity, until unless there is a collaboration, stakeholders, and commitment to do it, probably we will be able to achieve this TB elimination as well. But still there are very challenges. How the novel things, are handheld X-ray has come up, the site TB has come up, TrueNet has come up, but still there is not as much commitment. Of course, it needs an implementation research, that how can we have the pathodetect, TrueNet, and handheld X-ray spread across the all parts of the country, and everybody is being diagnosed, and early detection.
Yes, ma'am. That is some food for thought for some research, uh,
Yes.
research that you are giving, ma'am. We hope that all this interest of the secretaries that is there, that is not just only on paper, but it also comes into practice. You have given some examples of the practices that have
It
come.
has really come into practice. I take an example from district Gomti. Okay, district Gomti, state Tripura. He says, I don't want any ICMR officials to chair the meeting in my state. And we're so happy to do that. He says, I myself will chair the meeting. I will, because we want to have the, everybody must have known the IHCI project, Integrated Hypertension Control Initiative of India, which was again a project which has now come 8 years down the line, and still the states are struggling hard to integrate it into their program because they need resources. So on the tune of IHCI, we have another project on non-communicable diseases, that why a patient of diabetes who has been diagnosed should not be given the medication at that point of time. So this is okay, please tell us. I will monitor the anti-diabetic drugs are available. They are given for 30 days. They, pharmacists, they give medication for 3 days, 5 days, 7 days. Why the patient will come again at the end of 7 days? So there is a policy change. Now every facility they give the medication for 30 days. So this is the outcome of those implementation research, and Secretary Health says, I will chair my meeting on this project, which is a STAR NCD project being led by ICMR with the Ministry of Health. And not only that secretary, the secretary from where it is Chittoor district is in Telangana. Telangana. So that secretary also said, very nice initiative, and I myself will be interested. So things change, but only thing is that we have to communicate well that it is your program, country's program.
Yes, just finishing this topic of evidence to implementation, evidence to practice. Have you come across any example where evidence is there, very strong evidence is there, but yet implementation failed?
No, but I will say that yes, evidences will be there, but evidence implementation will fail when there is no commitment, when there is no systematically done methods. I'll just take an example. TB, I took one.
Yes.
No, we identified the TrueNet, early detection. We have the dots. It's an evidence that it works, but still we are not able to put. There are certain pitfalls. There are certain gaps which system or IR has to answer in different settings. And now this One Health is coming up.
Yeah.
Okay, it's a big program which we have the National One Health Conclave done last 10 days ago, where it's a PM agenda. But it is a beginning. Of course, the stakeholders are coming together. 13, at least 16 ministries have come together to address this One Health initiative. But how many interventions will go to the last mile? Because digital health is there, environment is there, animals are there, human health is there, and climates, all these urban ministries are there. Everybody has their intervention, but to make it successful, there has to be a pathway. We can't say that every intervention will be successful, but if it is effective, it will work.
My last question is that how did these newer interventions like artificial intelligence, digital health, how can we use them for implementation research if possible?
I think AI and machine learning, they are the newer upcoming. I will say it is not newer now, because every person is now so used to getting this artificial intelligence and all that, and it is cheaper. No, it is quicker. Not cheaper, it is quicker, and it can be customized. But sometimes, when we really take the help of AI for undertaking implementation research, probably in some settings it can be done. But by and large, when you talk about the whole system, until unless we have the good equipments in place, like I was there in Varanasi 2 days ago, where the chief medical officer and the state nodal officer for NCD, again for the Sankalp project, they were all sitting together, and they were very keen to work on again reduction of the neonatal mortality. But they say that how to record that temperature of that neonate. They wanted some devices to be available. They can't monitor the temperature, hypothermia or the jaundice or birth weight, or some patograms which will really affect early intervention by doing cesarean section. Of course it will have a role, but before they have a real role in implementation or improving the programs, they need to be customized, they need to have higher sensitivity, high specificity, and they have to be acceptable with the skill base. So still there will be a gap. I can't say that in our country, probably it will take another few years to get it appropriately implemented. But of course, I think that is the future.
We all are very thankful and privileged to have this session, ma'am, where you concised the whole things that you might have conducted so many workshops on for days. In the end, if you would like to give some advice to early clinical researchers, the postgraduate students, and early faculty, how they can proceed towards getting an interest and start doing some implementation research topics.
Yeah, so I think for early researchers, I will not say that you start doing implementation research since day one. First and foremost, if you are really interested into the research, that interest has to come from inside you. Okay, so the PGs or the young faculty from our specialty, community medicine, specifically are responsible for making some changes into the program that we have to accept later or the sooner. Okay, so I have been talking to many conferences and really lay down and again emphasize that if we are not working very closely with the state health system or with the health system per se where we are working, our recognition is going to be undermined. So you take an example from stalwarts that who have really made the difference into the systemic changes. So first and all, try to be a good researcher, have a interest inculcated into you in a particular domain. Choose your domain. You can have a broad base in the beginning of your career. You want to work on NCD, you work on NCD, you want to work on communicable, work on communicable. But sooner you decide what will be my area of work, that earlier it will be better. Better it will be for you. If you want to work on health economics, work on health economics. You want to work on health promotion, work on health promotion. So better identify the area of research, narrow down your area of research now, and start from small research. Like your internal research programs are there before you really jump into implementation research. And now implementation research is not so cheaper also, because it engages lot of resources. So our the project which is more of implementation pertaining projects are up to 5 crores or 8 crores or 4 to 8 crores, they are mostly ranging. We don't get much project in small grant because they work in a bigger area. But if you really want to work and with a novel idea into implementation research, come with the novel strategies. Come with that. Of course, if this is going to work upon, strengthen your base by having the preliminary studies, piloting studies, protocol studies. Do publish your work, do publish your reviews if you really want to come into the research. And lastly, I will end by saying, so if you want to excel your career, if you want to shine different than, you want to become red among all the whites, you have to do the research, you have to have the publications, you have to have extraordinary things which you will be able to deliver.
Thank you so much, ma'am. It was very inspiring.